Yeah, well, thanks for asking. It's been a really savage year, actually. So we're in wave two, or it might be wave three, depending on how you define it this time. And this last wave has been very, very, very much more savage than the first one, largely due to this new variant, the B variant, which is very much more transmissible. So we got a real hammering across Great Britain and in London. But yes, it is beginning to subside now with lockdown. So the numbers coming through to intensive care are falling. The discharge rate and the death rate is now greater than the number coming in. So we're just seeing that beginning to tail off now, thank heavens. And if we keep the lockdown in place, hopefully we'll now have control. So vaccines at the moment work well, and we've got to define what we mean by a vaccine working. So the first thing is, will the vaccine, if given to an individual, lower the risk of that individual contracting the disease or getting seriously unwell? And for the current variants of this virus that are out there, they're very effective. So well above the 90-odd% in stopping you getting significantly ill at all. And of course, that's what we're really interested in. It doesn't bother me greatly if I get a bit of a runny nose and feel slightly unwell. What I'm really interested in is, will it stop me ending up in a hospital or ventilated in an intensive care unit such as mine, or dying? And the vaccines are very, very good at doing that. The second question then is, are they good at a population level? Because of course, we have to remember that you have the vaccine partly for you, but you have the vaccine to a very large degree for everyone else. And to be effective at stopping transmission of the virus, you need at least 70% in this case, the population to be immune. So it does require 70% of us to step up to the plate, or more, hopefully a lot more, to get the vaccine. And with that, the transmission drops. We do know that the vaccine won't stop transmission completely, but it does have a very big impact. We're seeing the data from Israel and the United Kingdom showing that. The danger is if we don't all step up to the plate and we assume everyone else will get the vaccine, or we might not get the virus, we leave a pool of people that are still vulnerable. And when those people get that virus, amongst those people, the virus can mutate. And it could mutate into a form where the vaccine doesn't work as well. So that's the danger. So in summary, it works well across populations if we all have it. It works well for individuals now, but we do all have to get on and have it. And that is a worldwide issue too. Otherwise, we risk variants appearing for which the vaccine currently would not be effective. Well, the reluctance to the vaccine largely comes from misinformation and disinformation being spread on the web. And I've seen everything from the vaccine contains computer chips or electromagnetic waves in the form of 5G, or stuff saying it renders women infertile. None of these things are true. This disinformation is sometimes being spread deliberately, potentially by foreign nations who want to disrupt economies. So one has to think very carefully. It does look like these vaccines have been created in a massive hurry, but I can reassure everyone that no corners have been cut at all. The fact that we've got these vaccines so quickly is because, firstly, we'd had technological leaps in recent years that allowed that. And secondly, that colossal amounts of money and resource were focused on delivering them. So these vaccines are very effective. Now, will there be some people that will get side effects? Yes, there will. Will they be serious side effects? Possibly. There might be some that would appear, although the testing of these vaccines has shown them to be remarkably safe. But you've got to balance that, the same with any medical intervention, about the risk of not having it. And believe me, I have seen so many people die on intensive care units. I've seen people survive intensive care units, but they're there for weeks with tracheostomies and long-term illness. And we also know, of course, that even quite mild disease in significant numbers of people can lead to this thing called long COVID, so prolonged illness. So for me, it's a no-brainer. Would I have the vaccine? Yes. Have I had the vaccine? Yes. Do I think the balance of risk and benefit is in favor of the vaccine? Overwhelmingly so. I would much rather take an undefined tiny risk related to a vaccine than the very high risk that affects people like me of getting the virus. And the final point, of course, there may be people listening to this who are 25 years old and female and lean and healthy. Are they really going to get the virus and get very ill? Well, the answer is they're not going to get very ill, probably, but they might get the virus and spread it. And if they do, downstream, someone is likely to die. So there's a reason for us all to have the vaccine, for our own health, but those of our friends and family too. Well, one issue we've got about the spread of viruses is travel. And that can be within a city. You know, if you go to your next door neighbor or to visit a family or go to another city, you can spread the virus. But of course, air travel or long distance train travel allows massive opportunity. And prior to COVID outbreak, the reason it spread so vigorously around the world was that north of 142 people a second were boarding jet aircraft. Now, we can't go back to the world like that. That would not be safe. It would allow us to get the next pandemic spreading in just the same way. But there will be a need for people to travel. And the question is, how would they travel most safely? A vaccine passport, to my mind, is one way of allowing people to do that, because whilst it doesn't mean that you are certain not to have the virus or carry it, it does mean that that risk is very, very much lower. So my general principle would be try not to fly and travel when you don't need to. But if you do, I think the vaccine passport would be a very effective way of doing that, so long as it's properly regulated and not easy to forge and so forth. Not everyone is equally affected. So the biggest risk factor by miles for COVID and severe COVID is age. So children can get COVID and they can get an inflammatory response to it, which can be life-threatening, but it's very uncommon. And partly that appears to be because the virus itself gets into cells by binding on to a receptor called ACE2. And really, put simply, children and young adults, up teenage years, don't express very much ACE2. So it's harder for the virus to get in. Furthermore, in young people, they've got a lot better immune systems. Our immune systems as we age get weaker and weaker. So when you're young, harder to get the virus into the cells, and your immune system's pretty robust at clearing it. So age is a big effect, and after the age of 30, it's a log effect. So the risk at least doubles every 10 years of life for mortality, so that mortality can be up to 70% in people aged over 90, when under the age of 20, mortality rates are probably less than 1 in 20 million. It affects men more than women, for reasons we don't understand. There are a lot of immune regulating genes on X chromosomes, so it could be that. But there's a lot of evidence that estrogen is protective. We're finding fewer women with hormone replacement therapy postmenopausally coming to intensive care units. In fact, we're doing a trial of giving estrogen to men with acute COVID for that reason. So men outnumber women in critical care 2 to 1. The third thing is race. So we know Southeast Asians, particularly, and Black, Asian, and minority and ethnic groups are much more prevalently affected. Partly that's genetic. So there are genetic variants. There's a little chunk of Neanderthal DNA that's more prevalently expressed in some races than others that puts those individuals at much greater risk. And indeed, there are gene variants that create antibodies against some of your immune response chemicals that put you at greater risk as well. So race is partly for that reason, but it's also partly because of other factors too. So poverty and deprivation are major risk factors. At least half of people in British intensive care units are in the bottom 2 categories out of 5 for social deprivation. And this is partly because of diet and other access to health. We know poverty is linked to bad health worldwide. And it's also partly linked to the fact that you've got greater housing densities, that you've often got multi-generational families living together. With poverty, you've got people going to jobs where they can't not work, they have to go to work. And a lot of those jobs are maybe in transport or retail, where they're exposed to more people that puts them at greater risk. And some of that also then comes together with the biological risk factors. So obesity is a huge risk factor. Over a third of patients in British intensive care this way have been morbidly obese, BMI of more than 40, and over half of people have a BMI of more than 30. So obesity is a big risk factor, and so is diabetes, high blood pressure, and coronary vascular disease. So I suppose in sum, it does give us an opportunity here, doesn't it? Should we focus purely on having very expensive medicine and very expensive lockdowns to treat people when they get sick? Or would it not perhaps be better to focus on public health and try to create equity, help get better housing, make sure that we deal with poverty, and try to deal with things like active transport, healthy diets, and change taxation, so that our populations aren't obese and are fitter and healthier and less likely to contract disease. One of the things we've learned about health services worldwide, but the National Health Service too, is that it couldn't cope with its existing staffing levels with the number of people coming in with severe COVID. And there are only three options, really. The first is that you expand up the number of full-time staff in a health service, ready and waiting for a pandemic to happen. But that's not a good way to go about these matters. Firstly, it's very, very expensive to have people sitting around really not doing anything. And secondly, people get de-skilled. If you start spreading, let's say, all of your intensive care patients across 3 times as many intensive care units, people will see less disease and they'll be less current in their practice. The second option is you just accept that you can't deliver the service, in which case you either control the disease with massive lockdowns, or you accept that people are just going to die because your health service can't cope. We went for the lockdown approach, but also augmented our National Health Service. So we had people, retired doctors coming back, retired nurses, but also dental receptionists, physiotherapists, very quickly learning how to do basic intensive care under supervision. And my general feeling is this would be an excellent way forward. Every nation state, I imagine, Western economies is going to have massive unemployment anyway. People are going to be needing to be doing things that make them feel valuable and valued. I think that supporting the health service, which here is a state-run system, it's not for profit, people therefore feel that their volunteering time is good for them and good for other people. So I'd like to see that happen, actually. I think people could maintain their skills such that when these things happen again, they're available. And they will happen again. Unless we radically change farming practice, transgression and ingression into, let's say, rainforests and other areas of wildlife, forcing those wildlife to predate on each other, stripping out those ecosystems and massively increasing human population density in proximity to animals, we are going to have more of these pandemics. And remember, we've had 3 of them in 17 years. We had MERS, SARS-CoV-1, SARS-CoV-2, and that's if you discount the last few decades of HIV that probably came from a simian virus, or Ebola outbreak jumping from bats to humans. So 3 big ones in 17 years. We could very readily have another in the next 2 or 3 years, and it'd be good to be prepared. I'd like to think the experience of COVID has the potential to change the future of healthcare. It's certainly changed the way we practice healthcare now radically, at every level. So firstly, I think patients are much more aware of disease states and how they can be affected. They now understand the difference potentially between a virus and a bacteria, which they perhaps didn't before. We've had to reconfigure health services worldwide for remote access. So a lot of consultations now done on Zoom or by internet. My feeling is that's likely to continue, and it's likely to be more fleet of foot rather than dragging up a patient every 6 months to a building to be seen. I think there'll be a lot more flexibility in communication. It's allowed us to deploy new treatments very quickly without cutting corners. So vaccines, of course, were developed and deployed within 9 or 10 months of the disease appearing. We've been able to do trials in a way we didn't before. So in Great Britain, pretty much any trial that wasn't a COVID trial stopped. Everyone focused nationally on recruiting every patient we could to trials. And that meant that we got answers really quickly. We found the benefits of hydrocortisone, dexamethasone. We were able to show that some of the anti-malarial tablets didn't work. We were able to show that tocilizumab and remdesivir as drugs did work. And we were able to do those at pace. We were able to develop new technologies and deploy them. So my colleagues at UCL created a new breathing system for patients who required it. And that went from the concept idea being discussed on a Tuesday evening to delivery and validation and marking for use by Friday afternoon of the same week. So it's shown us that we can deliver the health service we've got more efficiently. We can run trials more efficiently. We can deliver technologies better. The challenge will be baking this into the systems of the health systems of the future, because the danger is we go back to the torpor of red tape and bureaucracy that slows everything down as it used to before. So lots of opportunity. And I think, again, for technological deployments and challenges, for instance, we know there are big differences between countries, between hospitals, in outcomes of patients. And some of that will be due to better practice, some practice inside a hospital that benefits the patient more. But because we haven't got all the data linked up, we can't find what those signals are. So it's a gauntlet being thrown down now, I think, for us to try to integrate data systems in countries so that we can find the signals for benefit and improve efficiency and effectiveness of healthcare systems too. So summary of the answer, yes, we really could radically change healthcare going forward, and we already have. The question is, will we? Will we bake in these changes societally, much in the same way as will we bake into society not having 142 people boarding a jet plane? Will we bake in society no longer the environmental impacts that lead to some of these pandemics? Well, AI can help predict pandemics. So, of course, it depends where the pandemics are coming from. So, in some ways, of course, by interrogation of genomes, we're now being able to apply machine learning and artificial intelligence to genomes, which would give us some clues about which pathogens were potentially more likely to cross over to humans. In this particular case, had we actually known if we'd been able to identify this virus out there in some animal population, we don't know where it actually came from. It probably originated in bats, but it might not have done. We would then have been able to screen it and go, wow, this is dangerous. That spike protein on that virus will dock with a human ACE2 receptor really strongly. That looks very dangerous indeed. So that would help. We know that it can help map with communicable diseases, where, of course, some of these things come from. So AI is being applied to weather patterns, standing water, and so forth to predict outbreaks of things like dengue and malaria. And there's increasing work going on, actually, to do that most and more effectively, to say, hang on, we can anticipate an outbreak of dengue in this area in 6 weeks' time or 8 weeks' time. Let's get mosquito nets out. Let's look at draining groundwater and so forth to do something. But those, of course, are more endemics inside countries compared to pandemics. I suppose the other thing, though, is in spotting the pandemic when it spreads and tracking its progress. And we know that even simple things like Google searches are effective in getting an idea, pretty accurate actually, of where viruses have got to and how fast they're spreading. When people start searching for headache, cough, COVID, people tend to do that more often, not just out of interest, but when one of their children or they have got a headache and a cough. There have been some work done actually from some of the voice recognition systems that you talk to without naming the brands, to ask them to order you something on Amazon or to search for a particular thing. Those microphones, of course, are always on. And AI has been applied to try to recognize coughing, for instance, in particular characteristics of, say, that that's a viral cough. I imagine that those sorts of processes are going to be more effective as well in helping us track pandemics and therefore isolate the individuals and the areas as well. So I think a lot of scope here. And of course, we could talk forever about the opportunities for AI in helping develop treatments, where it's got a massive opportunity for creating new specific drugs very, very fast to be effective against new infectious agents. I'm very concerned about mental health in society, actually. It's becoming an increasing problem, and it's for many decades has been an orphan problem not talked about. People with mental illness were shunned. Excuse me. For many years, people with mental health were shunned and not talked about. But we are better at talking about these things now. Mental health problems become increasingly prevalent, partly due to societal change. It's easier to victimize people online than it was by having to write a letter to someone. The youth particularly exposed to ideals they can't meet, to potentially pack attacks and savaging through the internet too. We used to live in communities. We used to live in family communities, often multi-generational, but now often people live a very isolated life. And these sorts of things have got much worse with COVID. Of course, everyone has faced pressures through work. In our case, working in hospitals has been a very savage experience. But of course, it's been very difficult too. If you've lost your job or you're worried about losing your job, let alone you're trying to homeschool your children, or you're with a partner that you already had relationship problems with anyway. I mean, let alone the fact we're social beasts. We've not been able to go out and see people for a drink or meet up for a theatre or go and watch sport together. So the mental health impacts have been substantial. And we know that we've decimated our economies. We're going to find long-term unemployment now, and a great disruption in society. So I think we will end up with big mental health problems. The challenge, I'm glad that it's being addressed, but the challenge will be, how do you do it? And again, there are two ways of dealing with these sorts of problems. The first is you talk to the person with the mental health problem and say, there, that must be very difficult. How can we support you best with your mental health problem? The other is trying to find ways of directly improving the mental health problem. And that will mean, how do we attach meaning to life? How do we give people employment that didn't have it? How do we create greater senses of community and support and social structure around people? There are two ways of dealing with problems, aren't there? If you're up to your neck in filth, one way is to learn to live with being up to your neck in filth. The other is for someone to dig you out of the filth in the first place. So I hope we're going to be dealing with both of those.